Hi everyone, thank you for tuning in for my lecture on pre-operative medications. I'm Dr. Windsor, and the content of this lecture coincides with the contents of Chapter 13 in the Pharmacology for the Surgical Technologist 5th edition textbook that is co-authored by Howe and Burton. Pre-operative medications are those that are given to our patients prior to surgery to maximize their safety and their comfort and to provide the best care possible. Surgical technologists must understand the classifications, purposes, and common drugs used to prepare the patient for surgery. So after this lecture, you should be able to define terms and abbreviations that are related to preoperative medications, as well as state the purposes of preoperative anesthesia evaluation. You should also be able to list the components of a preoperative evaluation, define and discuss preoperative medications, and lastly, explain the purpose and state examples of each group of preoperative medication. So we're going to kick off our discussion on preoperative medications with a review of some key terms. One group of medications, sedatives, have amnestic effects. And amnestics are agents that produce memory impairment. Goodness knows I don't need any help with that. At high doses, these agents produce something called anterograde amnesia. And this means that any events that occurred after the drug was given will not be remembered. Now, sometimes these drugs can also have something called a retrograde amnesia effect, which means that a few minutes prior to receiving the drug may be a bit fuzzy for the patient. Under the influence of these drugs, the patient may remain conscious, but they're not going to remember the events that occurred. So sadly, most of our patients are not going to remember the surgical tech. For this reason, also, some patients may think that they were anesthetized in the pre-op holding area. The literal translation for the word analgesia or analgesic means pertaining to without pain. So analgesics are those drugs that are designed to relieve pain. Anticholinergics are another category of medication that we're going to talk about in this chapter, and they are those that block the parasympathetic nerve impulses. So bear with me for a minute while we take a trip down memory lane. Remember, the autonomic nervous system is a part of our nervous system that is responsible for the automatic processes that occur in our bodies, right? We don't have to think about our heart beating. We don't have to think about breathing, regulating our temperature. Those are things that happen automatically. So the autonomic nervous system, the ANS, is comprised of two portions, and those are the sympathetic and parasympathetic nervous system. Now, the parasympathetic portion of the nervous system is what I like to refer to as the rest and digest portion. So this is what makes us feel like a couch potato after we've eaten a big meal and we just want to go and snuggle up and take a nap. The PNS, which is the parasympathetic nervous system, again, also helps us return to a calm state after the fight or flight response, which is the other part of the autonomic nervous system, and this is the sympathetic nervous system. The parasympathetic nervous system is also going to be responsible for regulating various hormones, decreasing heart rate, and repairing the body. So anticholinergic medications are going to block these parasympathetic nerve responses, okay? They also block certain receptors of the vagus nerve. Remember, that is cranial nerve number 10, and that process is referred to as vagolysis. So stay tuned for more about anticholinergics later on in the lecture. The last term here on this slide that I want to talk about is antisialagogue, which refers to the effect that anticholinergics have on the secretions of the respiratory tract and the digestive tract. So they're going to reduce those oral secretions as well as gastric secretions. A few more terms here. Anxiolysis is a term that is used to refer to the ability to relieve anxiety. In small doses, benzodiazepines are the most common type of sedative, and they can effectively control anxiety. It's scary having surgery, right? So our patients, it's going to be expected that they have a certain level of anxiety prior to and going into surgery. The term aspiration refers to a complication where gastric contents enters the lungs, and there is always a risk of aspiration during intubation as well as extubation of the patient, and we'll talk a little bit more about that later. Two more terms, and these are the last two that we're going to go over here before we get into the different medications that we're going to talk about. I want to review NPO and opioid. So NPO, nil per os, nothing by mouth, right? Most of our patients are asked to not eat or drink anything after midnight prior to their surgery, right? This is going to reduce the risk of aspiration during surgery. And then opioids are analgesics, so they are going to help relieve pain. So sometimes they're given preoperatively to do this. All drugs that have morphine-like effects, and it doesn't matter if they are natural, semi-synthetic, or synthetic drugs, they're all going to be referred to as opioids. So let's talk a bit about the preoperative evaluation. The preoperative evaluation is really the precursor to giving these preoperative medications, and the evaluation is going to be performed on every patient by the anesthesia care provider. And the main purpose of the pre-op evaluation is going to be to gather pertinent patient information to outline the optimal anesthetic plan for the patient. So the information is gathered from several different sources, which often include the patient's medical records, interviews, physical exam, and preoperative testing results. And during the evaluation, the anesthesia care provider is going to confirm that the patient's diagnosis, and they're also going to assess the patient's current medical condition. Now, certain conditions are going to put the patient at a higher risk for complication during the administration of anesthesia. The pre-op evaluation is also going to be used to identify any medication that the patient may be currently taking, which also includes over-the-counter medications and herbal supplements, as well as signs of potential drug abuse or any allergies that the patient might have. The preoperative evaluation usually consists of a questionnaire, and it may look a little bit different at each facility. Here's an example of one version of a pre-op evaluation questionnaire on your screen, but there's another example in the textbook on page 177, which is figure 13.1. And it's important to note that the patient is the one who completes this document. So after the patient has completed the pre-anesthesia questionnaire, they're going to receive a follow-up interview by the anesthesia care provider. This is going to give the anesthesia care provider an opportunity to ask questions and get clarification. It's also going to give the patient an opportunity to ask questions and get clarification as well. So forms are not the full extent of the preoperative evaluation. During that evaluation, the anesthesia care provider is also going to perform a physical examination of the patient. The pre-anesthesia physical exam is a complete assessment of the patient's physical status. So diabetes, diseases of the cardiovascular and respiratory systems are going to be of particular concern to the anesthesia care provider. The anesthesia care provider will also assess and score the patient's airway during the physical exam to determine if there is a potential risk of difficult airway management. There are two scoring systems that are typically used, and they're here on the screen for you. One is the American Society of Anesthesia score. It is also in your book on table 13.1, and then something else called the Mallampati score. And depending on how the preoperative evaluation turns out, other preoperative tests may be ordered by the anesthesia care provider. And some of those additional tests may include an EKG, pulmonary function studies, hemoglobin and hematocrit, coagulation studies, chemistry panels, and chest x-ray. This is by no means a comprehensive list. Other tests may be ordered as seen fit by the anesthesia care provider. So during the course of the preoperative evaluation, the anesthesia care provider will determine if the patient needs any preoperative medications. These medications are administered, like I said, to meet the patient's physiological and psychological needs. They're also categorized by their actions, and each category of medication, as we have been learning, has a specific purpose. It's important to note that prophylactic antibiotics are also medications that are going to be given preoperatively, but they are not going to be discussed in this lecture. So there are 4 groups of preoperative agents that I'm going to cover in this lecture, and they include sedatives, analgesics, anticholinergics, and various gastric agents. So I'm going to talk about each category in a bit more detail for you. So the first category of preoperative medication that we're going to learn about is sedatives. Sedatives are going to reduce the patient's anxiety, which is really common, like I said, among surgical patients. I don't know if any of you listening have had surgery before, but if you have, you understand what I'm talking about, or perhaps you've had someone that you love or care about that's had to have surgery, and you've kind of experienced secondhand the stress and the emotion and the anxiety that comes along with that. I know that I've had 11 surgeries myself, and the 11th one was no less scary than the first one. In fact, the last couple were probably more scary because I'd been working in the operating room and I knew all the things that they were going to do to me. So, sometimes ignorance is bliss. So these sedatives are going to help to reduce or relieve the patient's anxiety. And in most patients, these drugs also produce a little bit of sleepiness, and they might also have an amnestic effect as well. As I previously mentioned, benzodiazepines are going to be the most common sedatives used preoperatively, and they also have a really high solubility. So this means that they are going to be absorbed really quickly into the bloodstream. They can also easily cross the blood-brain barrier, and because of this, their onset is going to be extremely fast. However, they are highly attracted in some cases to receptor binding sites, and other times they are not. So that can impact their potency. Benzodiazepines are going to be administered intravenously, and the dosage is calculated based on the patient's weight in kilograms. So there are some minimal adverse effects associated with the administration of benzodiazepines, and some examples of benzodiazepines include diazepam, lorazepam, and midazolam, and the trade names are listed for you there in parentheses. Next, we're going to talk about analgesics. Like I mentioned before, analgesics are those that are given to relieve pain, and some patients, such as trauma patients or those that require the placement of some sort of invasive monitor, may require analgesics prior to surgery. Opioids, like we said before, are those analgesics that resemble opium or have morphine-like effects. In addition to relieving pain, opioids may also have a sedative effect. The administration of them preoperatively may reduce the amount of anesthesia needed during surgery as well. However, opioids are known to cause nausea and vomiting, as well as decrease respirations and reduce the motility of the intestines. So when opioids and benzodiazepines are given together, the respiratory system is going to be significantly depressed. And because of that, the anesthesia care provider is going to need to constantly monitor the patient's level of consciousness. Some examples of analgesics that are administered preoperatively include morphine and meperidine, which is Demerol. Morphine is a natural opioid that is made from the poppy plant. I don't know if you've seen The Wizard of Oz, but it makes me think of that big field of poppies, and the witch is like, poppies will make them sleep. Poppies will make them sleep. So opium comes from the poppy plant. That's what they use to make morphine with. Morphine is administered IV, and it has a very quick onset of about 2 to 5 minutes, and the effects can last anywhere from 2 to more than 4 hours. Meperidine is the most common synthetic opioid, and it is also given intravenously. It has an onset of 1 to 3 minutes, and it also has a similar duration to that of morphine, which is about 2 to 4 hours. So let's shift gears here and talk about anticholinergics. Anticholinergics are not routinely used preoperatively, but they might be indicated in specific instances to reduce mucus secretions of the respiratory and digestive tracts. As I mentioned previously, anticholinergics block vagus nerve receptors, which that's called vagolysis, and they do this by blocking the action of a neurotransmitter called acetylcholine. Remember, there's these little gaps in the neurons, right? And there's a junction there where the signal has to jump from one to the next. And the way that it does that is by some sort of neurotransmitter filling up that gap. And if that neurotransmitter is not present, then that nerve impulse is not going to progress past there. So acetylcholine is a key player in the transmission of the parasympathetic nerve impulses of that autonomic nervous system. And because the medications inhibit mucus secretions, they may be used when the patient is intubated or during procedures such as bronchoscopy or maxillofacial surgery. A common side effect of these drugs is increased heart rate. Now, anticholinergics are commonly used include atropine, scopolamine, and glycopyrrolate. And they are given intravenously, and they have different onsets and durations of action. Now, scopolamine and atropine can cross the blood-brain barrier, and because of this, the patient might also experience sedation or amnesia. Atropine is given IV, and it has an immediate onset and a very short duration of 15 to 30 minutes. And it's interesting to note that scopolamine is 3 times more potent than atropine. It's also given IV, it has an immediate onset, and its duration is about 30 to 60 minutes. Scopolamine has several therapeutic effects, so it can be classified in several categories, which include anti-sialagogue, sedative, and antiemetic. So scopolamine will also be presented in the discussion of gastric agents coming up here in a bit as an antiemetic. Lastly, glycopyrrolate is twice as potent as atropine and has an onset of about 1 minute and a duration of about 2 to 3 hours. Glycopyrrolate does not have the ability to cross the blood-brain barrier, and because of that, it's not going to cause sedation or amnesia. All right, the final group of preoperative medications is gastric drugs. Now, these agents are needed because, like I said before, surgery is scary, and that increases anxiety and fear in our patient. And because of that, the stress response is going to be initiated. And this can slow down or stop the digestive processes. So gastric agents are going to help minimize the possibility of aspiration and its potential damage to the lungs during anesthesia. Aspiration, right? That's contents from the stomach, comes up through the esophagus and gets breathed in to the lungs through the trachea, right? So when this happens, that can cause pneumonitis. And those that are at the highest risk for aspiration are going to be patients with any type of GI obstruction or history of gastroesophageal reflux disease. Also those with diabetes, obesity, or patients that are in labor or scheduled to have a C-section. The risk of aspiration is also highest during intubation and extubation, like I said before. And intubation is putting in the endotracheal tube, and extubation is the removal of that endotracheal tube. When we have a trauma situation, aspiration risk is also going to be high because it's a very real possibility that the patient has a full or partially full stomach. Several medications can be given to those patients that are at high risk of aspirating, and we're going to discuss 4 different categories of gastric agents, and those are antacids, histamine receptor antagonists, protein pump inhibitors, and antiemetics and gastrokinetics. So as I mentioned previously, gastric agents are administered to patients that are at an increased risk for vomiting and aspiration. Antacids are a category of gastric agents that are used to neutralize acid that is already in the stomach. And there are several antacids, such as Tums, that are available over the counter. There's not a lot of good research regarding the effectiveness of administering antacids pre-operatively. However, when it is indicated, they're going to give something called sodium citrate, or you might hear it called Bicitra. That's the most commonly given preoperative oral antacid. Now, sodium citrate is metabolized to sodium bicarbonate, which is NaHCO3, sodium bicarb. So sodium bicarb is what is going to neutralize the acid in the stomach. All right. Patients are typically given an oral dose of about 15 to 30 mLs. The onset is going to be immediate, and the duration is about 2 hours. So let's talk about H2 blockers, also referred to as histamine blockers. Those are the ones that block the production of gastric acid. So remember, antacids neutralize the acids. H2 blockers block the acid from being secreted, right? And there's these specialized cells in the stomach. They're called parietal cells. And so these H2 blockers stop these parietal cells from producing gastric acid. Some common over-the-counter H2 blockers that you might have heard of include Zantac, Pepcid, and Tagamet. Other examples, let's see. Okay, so those are my main examples, I guess. I do want to point out that I also have the generic name up there for you for each of these as well. So H2 blockers are most effective when they're administered 2 to 3 hours prior to intubation. And it's important to note that H2 blockers are not going to be given in emergency situations because they do not have the ability to reduce the amount of acid that is already in the stomach. So another class of gastric drugs are called protein pump inhibitors, or PPIs. These drugs are also referred to as prodrugs. And prodrugs are those that are given in an inactive form, and then the body helps us by changing them into an active form. So PPIs are unique in that they are not converted to active drugs in the liver, but in those parietal cell colliculus, or colliculi, which are these little canals into which the hydrochloric acid is secreted. So these drugs prevent that final step of gastric acid production by interfering with hydrogen and potassium ion exchange in this special potassium hydrogen pump, okay, proton pump. And these are located on the surface of the parietal cells. Some common PPIs include lansoprazole, esomeprazole, pantoprazole, and rabeprazole. And the trade names are there in parentheses for you. Now, lansoprazole, esomeprazole, and pantoprazole are available in a powder form. and these have to be reconstituted with IV saline prior to administration. And IV pantoprazole has the ability to reduce gastric acid in about 20 minutes. So there's also a subclass of gastric agents known as antiemetics and gastrokinetics. Antiemetics like Zofran are given pre-operatively to reduce nausea and minimize the possibility of vomiting. So those that are at the highest risk for post-op nausea and vomiting are pediatric patients, as well as those that receive opioids, barbiturates, or other hypnotic IV anesthetic agents such as etomidate. Females are also at a higher risk for post-op nausea and vomiting. The duration of the surgical procedure may also be a contributing factor in regards to post-op nausea and vomiting. Gastrokinetics, neuroleptics, and serotonin antagonists are 3 categories of medications that are used to treat post-op nausea and vomiting. Now, metoclopramide or Reglan is a gastrokinetic drug that stimulates the upper GI tract without stimulating gastric acid secretion. Droperidol, which is also called enapsine, is an antiemetic, and it also has sedative properties, but it isn't used that much because it increases the risk of some fatal cardiac arrhythmias. The most commonly used antiemetic is going to be Zofran or ondansetron, and it's relatively free from side effects. It can be given through the IV over a period of 2 to 5 minutes prior to induction, and it has a duration of about 12 to 24 hours, and it is extremely effective against post-op nausea and vomiting. Lastly, scopolamine. Scopolamine may also be given to prevent post-op nausea and vomiting, and it's usually administered by a dermal patch. Right? It's going to be applied to the skin the night before or just prior to surgery, and there are some known side effects, which include visual disturbances, dizziness, and sometimes dry mouth. And the patch typically contains 1.5 milligrams of medication and typically leave it in place for about 3 days. All right, so this is going to wrap up the discussion regarding preoperative medication. So thank you so much for listening and for your dedication to the profession of surgical technology, which is very near and dear to my heart. I greatly respect the time and effort that you are putting into honing your craft. Take care. I'll see you next time.